webinar for ACDN with Tiffany Wiles from Key to Care on ACFI education and how you can use it to build a better care plan as well as increase your revenue. So, Tiffany, would you be able to introduce yourself a bit and say where you've come from and what brought you to being an ACFI educator, please?
Absolutely. Thank you, Michael. So my name's Tiffany Wiles. I'm a registered nurse and I began nursing in 1986, so, you know, a whole lifetime ago. I was the first tertiary qualified group in New South Wales, and I have postgraduate training in gerontological studies. I've been in rural remote primary care as well as various middle and senior management roles within the aged care industry for about 12 years now. Obviously, in general nursing, the majority of people that we care for are elderly anyway, so aged care has been a feature my whole career. In 2013, after doing some consultancy and partnership, I started Key to Care to address the inequity between the funding entitlements and the funding actuals, and to build capacity and independent sustainable growth so that we could provide quality care for our elders. One of the things that in my leadership roles was, you know, the difficulties with engaging people and having assessments completed on time and claims submitted on time. So it was important for me to be able to provide the rationales for the importance of these things.
Okay, thank you very much. Now we know who you are. I'll hand over the presentation for you, and if you'd walk through that. Everyone, at the end of the presentation, the aim, Tiffany wanted to walk you through the thinking process, etc., some takeaways, the service that Key to Care provides, and then we'll go into Q&A. So any question you have, you can either jot them straight into the chat area and I will address them at the end or ask them at the end, or if you want to write them down and ask Tiffany at the end, that's also an option. But I'll hand it over to you, Tiffany.
Thanks, Michael. So what I thought we'd talk about today is ACFI Disruptors, some examples of our achievements and offerings, our approach, a new way of thinking, an importance of diagnosis, normal ageing, the impact of ageing and disease, aspects of assessment, some impacts on Standard 2 around accreditation, and how we might be able to help you. Obviously, this is a lot of information and I'll try to be as brief and succinct, but as offering as much information as I possibly can within the time frames.
And I'll just jump in there. The slides will be available to everyone who's on the webinar today, so you don't have to quickly take down notes. We'll send them out to you.
Absolutely. So the first bit of information is about ACFI Disruptors. Why don't we do it very well? The information around care delivery, lack of focus and complexity with documentation is important to recognise, because once you recognise your disruptors, you can actually do something about them to create more of a flow. In care delivery, funding activities are seen as not essential. There's that real little red hen mentality where it's not my job. Everyone wants to eat the loaf of bread, but they don't want to plant the seeds or water the plants or harvest the seeds and things like that to get the wheat to make the bread. So very much a little red hen mentality. Quite often staff don't know their residents very well, and care staff know residents a lot better than registered nurses do. Which is a shame, because the registered nurses are the key decision makers in clinical care. So there needs to be a close teamwork between the two groups. There are too many other tasks and you know, funding is not seen as a priority. The differing priorities, you know, where the ACFI coordinator wants things done and care staff just want care. So we have this angst between roles. A lack of focus with knowledge. The ACFI training that's provided doesn't give you the tools for success. It doesn't teach you how to put your clinical information into the funding model. There are some accountability issues where registered nurse feel that they can't say that bit of information because my registration's at risk, which is sad really, because we're using a funding model. It's really a fear tactic that's used. ACFI is seen as a workflow disruption, and there's a lack of engagement. The other thing around that, or associated with the registration being at risk, is the $10,000 fine for facilities now for fraudulent claiming, or there to be demonstrated repeated fraudulent claiming. There is, the department has put fear into people around that, which is also sad. What I want to do is reduce this whole cat and mouse game between the department and providers, so that we can be all on the same page and really look out for our residents. So one of the other the disruptors is the complex documentation. It's burdensome. We don't know how to use the mandatory assessments particularly well. We don't know what non-mandatory assessments to use. Organisations will have their own documentation systems, but what ones do we use? What pain assessments do we use for ACFI? What will validate? What doesn't validate? There's a lack of congruence with too many contributors to the claiming process. Quite often the ACFI coordinator will hand out assessments to registered nurses or other people in the team, and each of those people fill out the forms without considering the information on other parts of the assessment. So there's incongruence, which leads to loss of validation. And of course, multiple points of data recording can lead to failure. So the effects of that, or the effect of getting this stuff right, is seen here. The financial rewards that Key to Care has been proud to be involved in are these. These are our recent achievements. All of them have had zero funding loss at validation, so all sustained validation. Not a penny, not one thing lost, which is something that I'm really proud of. 19 beds with an average daily increase of $121.88 a day, which is a total increase of nearly $850,000. You can see there 40 beds with a $1.8 million increase, and a 20 bed with a nearly doubling of their income, leading to sustainability for that really small facility. This is something that we're really, really proud of, and we'd be really pleased to be able to ensure this sort of success across the nation. I think that if we could look at this sort of increase, then we'd be so well resourced and paying, reasonable wages for good quality people. Our overarching principle is to achieve the highest possible quality of life for Australians living in our aged care community. It's a non-specific overarching principle, because this is what we want to achieve: a quality of life for everybody. And not just in residential care, we want to have it flow over into the communities where our residential care facilities are. So the facility there that I showed earlier, the 20 beds where we've doubled the increase, doubled their income, that actually means that people in that small community can stay in their community when they age. So that's a really big bonus for us. We focus on assessing the care requirements of residents and to fit that carefully into the funding model. It's the biggest funding variable within our system. Obviously, there are other funding streams, but this is the biggest variable. If we can bring that stability and predictability into our funding, then, it's our residents that benefit, and demonstrated benefit to the wider community as well. We look at a new way of thinking. We're looking at consistent engagement of care staff, connecting them to their why, which is really important. Why do we do what we do? Because they're the direct carers, they're that coalface point of care delivery, and we need them to understand why they do what they do. We're going to look at some new ideas for assessment. What are the gaps? Quite often we assess what the known is and not what the gaps are. The known actually doesn't guide our care, it's the gaps that guide care. And we promote a real team model. And I know it's pretty novel that we work as a team, but ACFI success is, teamwork is vital. So why do we worry about diagnosis? Firstly, it's a requirement for the funding tool to record the currently impacting diagnosis. There is an opportunity when claiming online to record only 3 currently impacting diagnosis. However, in your answer appraisal pack, I recommend listing all the diagnosis. The purpose of that is to paint a picture so the overall condition of the resident becomes more obvious. Validators will, if you put down a diagnosis of insulin-dependent diabetes, they will see that and often use that one thing in isolation. Validators aren't all clinicians, so it's important to paint this picture. Now, if I was listing diagnosis for somebody with diabetes, there's a whole heap of potentials that come up depending on their disease progression and where they're at as far as side effects or detrimental effects of the disease. So I would be listing, I'm not going to put the ACAP codes in my list here, but I'm just going to list you. So if somebody had insulin-dependent diabetes, I would also look at nutritional deficiencies, vascular dementia, nervous tension, stress, angina, depression, peripheral neuropathy, atherosclerosis, cataracts, glaucoma, poor vision, hearing loss, diarrhea and constipation can be a feature. Amputations often present, as you know, nausea, vomiting, renal failure, rash or skin eruptions, pain, abnormal gait, dizziness, falls, restlessness and agitation, malaise and fatigue. So that's 23 diagnoses and signs and symptoms that have come out of one broad diagnosis. So it's important to be able to paint the picture about what your resident's looking like. So if you just put insulin-dependent diabetes without painting the picture of the other 22 signs and symptoms or conditions, then you're very limited in the colour that you put into this person. So secondly, a diagnosis gives you an idea about the care pathway. I'm going to use insulin-dependent diabetes as the example again and just drill down a little bit more into the sorts of things that I've just talked about and show you or demonstrate to you how that fits into the funding model. So with any disease or disorder, there's going to be a minimum expectation regarding care or a general care pathway that you can expect most residents with that condition to follow. Beg your pardon. So when we're looking at insulin-dependent diabetes, we need to consider the effects of the disease on vision, circulation, sensation, renal function, and all of the above. When we're looking at ACFI, they'll be on injected insulin, which relates directly to question 11 medications. They will need regular monitoring of BGLs, question 12 BGL monitoring. There will be issues around nutrition and the sort of food that's appropriate for consumption, foods to avoid, with possible issues around residents' cooperation. As well as that, the neuropathy or the nerve damage involved in diabetes can cause nausea, vomiting, diarrhea and constipation, and that's why I listed those things earlier. They may have poor or restricted vision or blindness related to retinal neuropathy and or diabetic macular edema, with a doubling of the risk of people with diabetes developing glaucoma and a 5-fold incidence of cataracts. I wonder if you have looked at those statistics before. If you can't see what you're doing, then personal hygiene and toileting are going to be an issue. And if you can't see where you're going, then mobility and toileting are going to be an issue. And if you can't see what you're eating, well, nutritionally, you're going to have a problem. So it affects your whole ideal domain. They're more likely to have impaired peripheral circulation and therefore a higher risk of pressure ulcer development and poor wound healing. Your Waterlow will indicate a higher overall risk and may indicate the need for pressure area care under question 12.5, if they are not independently mobile, that is. Diabetes increases the risk of heart disease and stroke, causing angina and high blood pressure that should be monitored periodically, especially if they are on medications. So blood pressure monitoring is claimable within question 12.1. Although it's worth fewer points these days, it's still a point and contributes to your claim. If they have insulin-dependent diabetes as well as hypertension treated with medication to lower the blood pressure, then they are likely to experience dizziness and even falls, which relates to question 2 mobility, specifically transfers. The highest risk of falls is from a sitting to standing transfer. So if dizziness is present in people with insulin-dependent diabetes, then it may well be an intervention for safety to provide support with transfers. High-risk feet related to poor circulation and reduction in sensation means they are more likely to require podiatry intervention. So there's no ACFI claim for podiatry intervention, but it's good care, so this is why we recommend it. They may experience tingling and numbness, burning or pain, which affects mobility, which is question 2. So along with that, there's a higher incidence of amputations with obvious mobility implications. Quite often you'll have people with a bilateral amputation, which severely limits mobility. Nephropathy or kidney disease can lead to significant loss in renal function with a loss of glomerular filtration, leading to less urine output and higher concentration of circulating medications. They are not efficiently excreted and increase the effect of some medications and may lead to undesirable medication side effects, for example, with dizziness in treating hypertension. Diabetics are more prone to skin problems from bacterial or fungal sources, so personal hygiene question 3 will be really important, and the need for some intervention for maintenance of skin integrity under question 12.12b will also impact care and increase funding. Hearing problems are common in people with diabetes, and that might lead to social isolation and withdrawal and contribute to the development or worsening of question 10, depression, or even give rise to some behavioural issues, which is covered in the second domain. There's also a link between diabetes and a higher incidence of Alzheimer's disease affecting cognition. So as you can see, how knowing about disease and examining the areas where you may expect to find issues will also affect the quality of care provided, as well as the possibility of attracting more appropriate funding level. Generally, in senescence, disease doesn't occur in isolation. There are numerous comorbid conditions that compound the issues and paint a different picture altogether. So people with diabetes that have had an amputation, that may have also had a stroke, that are not mobile, you can see the picture how it sort of worsens when you have these comorbid conditions. There's a couple of slides here about getting old and how it's not a walk in the park. So we're going to be able to provide you with these slides, so I'm not going to read through these, but you can see generally how it affects all systems and can specifically affect ADL domain. But this slide here is 5 areas that, if I can use the diabetes as the case study again, or the example, that's a metabolic disorder. There are normal aging changes in metabolism. You put diabetes on top of that, then you have this shifting body fat, this muscle mass issue, slower metabolism, increase in obesity, and looking at bariatric issues. The circulation then is affected, the increase in breathlessness, and the kidney issues, as I've said before, with higher circulating medicines, high concentration of circulating medicines, so their half-life is not, they're not excreted as quickly as they need to be. And the interesting thing here, and this is quite interesting and a little bit scary, is that from the age of 30, the brain size and neural network and blood flow decreases. And although there's some adaptation, it's still a real thing. I don't know how many of you walk around the house looking for your keys, but I had this, I'll give you an example of my loss of brain size. I was looking for my glasses one day and I looked all around the house and I couldn't find them until I walked past the mirror and I was wearing them. It wasn't even on the top of my head like you wear your sunglasses, I was actually wearing them on my face, using them to see, but I'd habituated to them being there that I couldn't find them. I thought they were lost. So, even more learned people can have the effects of aging. We have less recall, short-term memory loss is affected, and of course that then affects your ability to care for yourself. And the need for repetition and reinforcement, constant reinforcement is high in normal aging. The areas for decline as well, with the spatial ability, the dizziness. I don't know if you notice how people, when they stand up, they reach out to actually feel the table, or before they sit down, they put their hands down to make sure the chair is there, so that they have that security of that spatial awareness. When we're looking at clinical assessment, I like to look at 5 specific areas. And I'll just go through these one at a time, and hopefully with enough detail, but enough detail to be of use to you without overdoing it too much so that you're bored. So in the sensory area, we're looking at the normal 5 senses, so vision, hearing, taste, smell, and touch. And obviously, like I said before, if you can't see where you're going, or if you can't see your food, or if you have a loss of central vision, these things are going to affect the way you care for yourself and the way carers care for you if you need support. But the things that we forget is that we actually have 7 senses. The vestibular sense is that spatial perception, movement, both vertical and linear, balance, equilibrium. So, that issues around dizziness, as well as the proprioception, which is the sense that brings it all together, brings all the other senses together, which is closely related to this vestibular sense. It gives us an awareness of our body's position and how it relates to the physical environment. So it allows you to know your space in the world. And that reduces as you get older. So some physical issues. We look at issues related to function and strengths and deficits. So examples would be frailty, CVAs, swallowing difficulties, dexterity issues, both fine and gross motor skills, pain, especially in the back and the joints, range of movement issues, fatigue, weakness, stiffness in their joints, breathlessness, amputations, and I don't know if you've heard of a condition called lateral neglect, particularly in people who have had CVAs, where they have a hemiplegia, where they can't sense that one side of their body. They neglect that side completely. They don't even realise it's there from a cognitive sense. Neurologically, we look at assessing people related to impact of diseases such as multiple sclerosis, cerebral palsy, motor neurone disease, and brain injuries. So they can be either traumatic or self-induced with alcoholism or other chemical effects. Autism, athetoid and spastic movements, paraplegia or quadriplegia. There's a lot of neurological issues that I haven't mentioned, including Parkinson's disease, which is fairly common, that we need to consider in all of our assessments. The mental and psychological issues, confusion, disorientation, paranoia, neuroses like anorexia, hypochondria, depression, dysthymia, other mood states, poor executive functioning ability. They can't remember the steps in a sequence. They might put their skirt on before their knickers, or they might even forget their knickers altogether. And quite often there's a lack of ability to initiate any activities. The memory issues where they can't find the toilet, they can't remember where the toilet is, and that leads to care issues as well. Emotional issues, things like anxiety and fear. Emotional issues often, their root causes around fear. Fear of incontinence, fear of falling, self-esteem issues, a loss of appetite, curbing fluids because they might wet their pants. There's a lack of purpose and disinterest. I mentioned the issues around chemicals before. So they're the side effects of medications. A lot of medications will cause drowsiness, dizziness, appetite suppression, or even enhancement, sometimes nausea, and of course most of our elderly are chemical bombs just waiting to happen because of the issues with polypharmacy and the toxic effect of interactions of all their medications. Cultural issues are something, unless you're a culturally specific facility, is something that's not often catered for or even considered widely. So culturally, we look at the sorts of foods that people would eat, the traditions, the special days that they celebrate, schedules, the religious impact. Jewish facilities and Islamic facilities often will have a completely different routine or diet or schedule to other facilities. Attitudes, cultural attitudes are often at least interesting. So I don't know how many of you would remember all the jokes around the English bathing only weekly. Some of them probably still do, but I really don't know. I've had a lot of experience with Indigenous health and have worked in far north Queensland right up to Thursday Island in the Torres Strait. And one of the interesting cultural things that it's actually been quite amusing, but just interesting to manage, is the concept of a bush toilet. Totally normal in many Indigenous communities to use the environment to void in, but obviously not appropriate in residential aged care. And managing those situations and managing the cultural aspects of care is yes, very, very interesting. Everything that we do in ACFI or that care does in our services and the support that we provide, has positive effects in Standard 2. And you can see by the list there that many of the outcomes are affected by ACFI. I'm not going to go through each of them, but if you look here at pain management, most people would actually go to the obvious point, which is question 12, where you can use heat packs, massage, allied health support to manage pain. But we forget that it also relates to ACFI 1, nutrition, ACFI 2, mobility, ACFI 3, personal hygiene, ACFI 4, toileting, and ACFI 5, continence. You're going to have a loss of appetite if, like for ACFI 1, if you're in pain, you're going to have a loss of appetite. You're not going to feel like eating. You're not going to want to move because of your pain. If you manage pain well, then mobility increases. There may be a need for support with ACFI 2 mobility related to pain. The same with personal hygiene, with being able to have a range of movement sufficient to reach all body parts. And of course, if you can't reach all your body parts, that's where you need to have support for the residents so that they do have good hygiene. And of course, if there's an issue around pain, getting up to the toilet, using the toilet is going to be an issue, and also affects continence, where if it takes you a long time to, or more than, longer than usual to get from point A to point B because of pain, then you could be incontinent on the way. That ties in with mobility and dexterity and rehabilitation, where we have a similar issue where that the pain actually then connects to this other outcome with mobility, with personal hygiene, with toileting and continence. Mobility, dexterity, rehabilitation also affects your mood, and there are possible claims in question 12. So overall, although ACFI is not a comprehensive assessment tool, it's a reasonable funding model where it impacts fairly well across the board in Standard 2. And when you're looking at continuous improvement, we also look at encouraging you to record the positive aspects of our services and what you're actually doing in your continuous improvement record, and also recording staff education and staff development. The human rewards. So why we do what we do? Well, primarily it's for outcomes for residents. The issues there listed, fewer falls, better skin care, mood elevation. There's an increase across, or an improvement in clinical indicators across the board. And there's an impact on organisational culture as well. Generally, a happier place to work and to be. The compliance that I've listed there is about resident compliance cooperation rather than compliance accreditation. The workforce satisfaction, I think this is a really important area. When people understand why they do what they do, they actually have an increase in job satisfaction, they get to focus on their residents and care, they get to contribute to the bigger picture, and they have it often gives them that ability to have a career path. If they work through this assisting with ACFI, then that empowers them to the next step. And quite often I've had people working with me who have gone on to do their enrolled nurses training and registered nurses training as well. So the overall increase in satisfaction of the workforce is pleasing to see. We generally see an improvement in documentation. Key to Care has our own suite of documentation and assessments that we offer to our clients. But generally speaking, aside from that, There's an improvement in the language that we use. There's more clear and concise care planning, more up-to-date guided outcomes. We have a defined process with clear allocations of responsibility through the system. And of course, the thing that most people want to see, but is my least priority, I suppose, is the increased financial sustainability. You know, if you have more money, you're actually able to attract and retain good quality staff. And of course, there's more resources for residents when you have more money. But overall, you can see that the picture of what we do, why we do, it's a really positive one, I think. So our solutions are listed here. I'll just go through them individually very quickly. We want to ensure that residents are fully funded and that their unique care needs are addressed, so that even though we're looking at a funding model which has 12 questions and not a comprehensive assessment package, we still make recommendations about the care overall and include care plan production that is really comprehensive. What we do is come to your site and assess every resident, and we retrain your staff in ACFI, or maybe initially train them in ACFI. A lot of people really don't understand what it is, but yeah, we start at the basics and we cover everybody. Your physios might not understand the impact of what they do and how it works. You might have physios that are only, you know, doing falls assessments or things like that, but I hope you're using them productively rather than doing it that way. GPs quite often don't understand their contribution, and they have an important contribution. So we also go to the GPs and have a discussion about how they can support the process and how they can support the facilities. And the residents learn too, and once they learn that what you're doing is helping to support their care, they really engage with that. One of our brilliant things that we don't charge you anything until we make you some money. My PowerPoint's gone. Okay, there we go. So there's no risk when we do. We've decided to do it this way so that it's affordable. There's no risk, and everybody benefits. Our fees and charges are based on 20% of the increases for the first 12 months from the date of the claim, which is a full half of what other companies actually charge for ACFI consultancy services. We want to help. Obviously, we also need to be sustainable in our own business, but our primary goal is to help. Plus, we guarantee to refund our fee if there's any loss at validation. So far, we haven't lost anything. Everything's validated because of our thorough evidencing. Generally, we only take on 3 aged care groups a year related to the time commitment for each, but perhaps only 1 if it's a big group. So there is a big time commitment, and your success is our success, and that takes time. So there's some takeaways. Don't worry about writing this all down because we're going to give you the slides. All you need to do is email Michael and he'll forward them to you. But this is some general information here about success with your ACFI claims. The language that you use is really important. The validators are focusing on the nuances of meaning to claw back funds. So it's really important to use or to get rid of using really non-specific terms like occasionally. Get rid of it from the vocabulary. Be confident in your descriptive terms. This lack of confidence I've put here, they sense your fear, you know, like predators. They actually do pick up on those things and will argue the point if your documentation lacks that confidence. I would recommend that you case conference all your ACFI claims. Interview staff from all shifts. You know, things happen over time where you might not see things, and so often I have staff say, "Oh, I can't sign that because I haven't seen them do that." Well, you need to then ask somebody on a different shift. So, for example, on the night shift, you might have people seeing behaviours that are really prevalent on night shift. So all the shifts needs to be involved. Getting that broad picture is really, really important. So an observation in isolation is okay, but consolidating that with observation after observation is an important thing to do. So, and behaviours are put here, look at behaviours happen in clusters and often at peak care times. So quite often you're busy, you're not seeing the behaviours. It's important for eyes and ears to be able to see and record what's happening. And of course you don't have to record those things immediately. They can be recorded, you know, if you're doing your notes at the end of the shift, then that's okay to record them then as well. I think it's important to identify your care as well as your funding targets based on your case conference data. Quite often you can collect that information and then be able to say, okay, we've got a medium in ADL domain. I think we've probably got a low in behaviours. She's a really good girl. But, you know, because of the mobility issues in the first domain, we're going to have some pressure area care issues, and we might be able to look at a low or a medium with complex healthcare. So you should be able to actually go through each of the questions and make a reasonable projection about what your funding is going to be, and that's going to advise, you know, that's going to keep your finance people happy. And it's also going to give, I've found that when you connect the work done to the dollar value, it's like I've said to people, okay, we're going to make 40 grand this year by doing this documentation, by collecting this information and contributing to this funding model, by just recording what we already do. So engaging people along those lines is really important, and having those projection targets. Use the carers. Carers are the eyes and ears of the facility. It's important to empower them to make observations. They're in the shower with people. They, you know, registered nurses and high-level decision makers do not see people's skin or their bottoms or, you know, those intimate areas that are important for assessments. And quite often there's a lot of behaviours around issues in the shower and stuff as well. So use the carers' information, ask them questions, give them, empower them with knowledge about what to look for and why they're looking for it. I would recommend that all ACFI claims are checked by another person for congruence. If you have a claim for, this happens quite often, if you have a claim for assistance with transfers in mobility and independent with toileting, then a validator is going to look back at your mobility claim and said, well, you're not assisting with them with their transfer on and off the toilet, so do they actually have a mobility issue? So you've got to make sure that all your information, all your ducks are lined up in a row, and that your information is solid. So it's important to have you more than one person, more than one set of eyes looking at the claim. And that's what I do. I don't put in any claim unless I've looked at it myself, and you know, it's very time consuming, but it's certainly worth it. Residents often will respond in a way that they think, you know, they'll respond with an answer that they think you want to hear, because they're afraid of you changing something or doing something different. And it's important to remember that creating those trusting relationships will give honesty from your residents. And the one thing I find really important is that self-disclosure equals disclosure from your residents. So, you know, if I say, oh my goodness, I've got little waterworks problems, you know, you're twice my age, you must have this problem. And then they sort of say, it's safe then for them to be able to respond to you in a way that is appropriate, or that is honest at least. The other thing I would say is always use your area for comments in the assessment. It really, really, really lends weight and cements in the information if you're using comments. Some clinical information here, and I think this is really important, and this is stuff that you can take away and share with your staff now. So just an area around chronic wounds. The World Health Organization defines a chronic wound as one that has failed to progress through the phases of healing in an orderly and timely fashion. Now, I know when I go through training, people say, oh, but a chronic wound it has to be 3 months old. And I say, well, no, it doesn't, because that's not the definition. If you look at a surgical wound where you've got good wound closure and healing, stitches are removed in 7 to 10 days, then you could think, well, that's normal wound healing. Anything outside that, by this definition, could be defined as a chronic wound. And so if you've got a wound that's, like, say you have a skin tear, it's not healing after 2 or 3 weeks, then there's an opportunity for a claim to be put in, because it's not following the normal phase of wound healing. By definition, it fits. If you have all your criteria, all all your boxes ticked, you've got your wound assessments and your evidencing fine, then absolutely this is an area where you can claim. Now, the other area is continence. You know, I worked in a place where I was doing a reassessment. There was a 96-year-old lady that had 4 children, and no staff could come to tell me, they said, no, she's continent. I said, rubbish, go back and look. So continence is really like death or pregnancy. There's no halfways about it. You can't just be a little bit dead or slightly pregnant. It's either you are or you aren't. Now, this lady that was 96 and had the 4 children, I went into her bathroom. She's rinsing out her knickers. She is actually folding up face washes and men's handkerchiefs and putting them into her underwear. But no, she's not incontinent. She's good. So you need to be a bit of a sleuth around detecting things sometimes. But remember, a drop or a cup or a pad full is still incontinence. You know, popular media talks about it as being light bladder leakage. You know, I believe in calling a spade a spade. If you're incontinent, you're incontinent. You know, there's no problem with that. It just provides us an opportunity to support that and give you pads or change our toileting strategies. Now, we think the last 2 points here, you think that only the lucky ones don't experience pain. No, a lot of people in residential aged care do have pain. They don't tell you about it, but you can observe it in the way they walk, the way they move, their slowness. Old people wear pain like a cloak. They put it on the morning when they get dressed. They habituate to the presence of it. But it does hurt, and you can often see facial grimacing and that sort of stuff. So I recommend, so you could have a verbal resident, but I also would say use the observations that you would use in your Abbey pain scale for non-verbal residents. Look at the grimacing, look at how people move, look at gait and functional reach. Why can't people reach so far? Why can't they put their arms right up? Well, it hurts. So use that information in your pain assessments and ask. I'll just give you a quick story. I'm not sure what time I'm going at here, but I had a gentleman who also they couldn't get an admission from him about pain. And I didn't go in and speak to him about pain. What I went and talked to him about was his career, what he did for a job. And he was a scaffolder, or he had been a scaffolder. And I said to him, oh my goodness, Michael, that must have been really, carrying heavy equipment. Geez, your back must hurt. And of course, oh yeah, and my knees, he says. So approach things from a different angle. Now, with the Cornell, the thing to remember when you're recording in the comments, so often I see, rainbows and unicorns recorded there. It's not a happiness scale, it's a depression scale. So please answer the questions to reflect what people are actually doing, what they're actually feeling. And recording that sort of information doesn't reflect the quality of care, it reflects the resident's mood. So that's it for my takeaways at the moment, and I suppose I'm going to wrap up now, and so I'm going to hand you back over to Michael. Listen, thank you very much for listening.
Thank you very much, Tiffany. That was a lot of information in a relatively short time, and as both of us said, you'll get the slides sent out to you, so you don't have to try and remember everything. Just to recap, Tiffany's service, Key to Care, what they can do is actually come out and help you on site to train your staff properly in ACFI, because even if you have the knowledge yourselves, like a lot of training on site in a home, you're usually under-resourced and don't have the time to do it. So let Tiffany come and do that. Tiffany, I believe you've got an offer for the people on the webinar as well?
Absolutely. Usually we charge $500 for coming out and doing a 10% sample to let you know how you're travelling with your ACFI and where your possible claiming could be. Today, for the people on the webinar, we're offering that as a free service. We can come to your site, we can do it as a desk audit so that we don't disrupt your workflow. But yes, certainly we're offering that for free today.
That is excellent. One of the things I keep finding is people who say they've got a challenge. I was at a workforce conference the other week, last month, and a lady was saying, our HR department's only 2.5 people, so we don't have here and here. And I kept offering solutions, saying, well, here's a team who can help this. Oh, no, we don't trust them. Oh, we've used that and it didn't work. Oh, but that's why we're so run off our feet. Most of the people out there trying to offer you solutions, there are some guys who are just in it for the money, but most people like Tiffany have got a background in this space. They've got a lot of knowledge, and they bend over backwards to make it a great service and also an affordable service, because they know, because they've been in the same position as you, that a business case has to be put forward to your boss as to why you bring in this provider or bring in this trainer or get a new IT system. So use the services that are out there like Tiffany, because it changes your world, seriously. Some of the providers I've spoken to, having that additional funding coming through the door, we'll start on the team side, having teams who are confident in what they do, because this ACFI checklist in their head makes them a better carer. So that gives them confidence in what they do, and you can see that in the way they walk. So it starts building team dynamics, and you start changing the entire culture of a facility. So when ACDN has come on site to talk about other things, that facility, they were lining up out the door going, what can I do next? It is chalk and cheese to another facility where they don't feel confident, they feel maybe picked on by the nurses or the management, they don't want to learn, they fight against any change. It really is a game changer for culture. So all these little things, there's no one silver bullet, they make that difference. So now, any questions do you have? If you down in the chat box, if you'd like to list any questions that you have for Tiffany, it can be about the presentation you've seen today, any challenges that you have in ACFI anyway, any questions? When Tiffany comes on site, how she works, or all those kind of things. Any questions like that, just whack them into the chat area and we will start answering them. We'll just be going for a few minutes. I know we've hit 1 o'clock, so we'll be finished within the next 5 or so minutes so that everyone can get on with their day. But any questions, here's the time to ask it. Any comments on the presentation as well, just whack them down into the chat area. You're welcome, Denise. The presentation will be, as I said, sent out to everyone. In fact, I think I can download it as a video, so you actually get the commentary that goes with all the slides as well as just the slides themselves.
That'd be good, because that will help with dissemination of the information throughout the facilities, Michael.
Yep, definitely. Lots of thank yous coming through, but no questions. Maybe you answered everything, Tiffany.
Oh, I hope so. Probably not, though. There's plenty of questions usually that come up, and perhaps if you have other questions that you think of later, my email address is there, also my phone number. So feel free to send me an email, drop me a line, and I'll try to answer your questions and address your issues as best I can. Excellent.
Okay, if there's no questions coming through, we'll halt the webinar there. Thank you everyone for attending today. As I said, I come from ACDN, which is the Aged Care Development Network. That one passport and the dashboards and the connectivity from an individual point of view through to your systems, that's all what we provide to the industry. It's got over 10,000 individual workers in the system as it is. If you're having issues or challenges, or a small HR department and you want some advice and help in that area, please give us a call. That service is free for an individual in aged care. There are some fee-for-service things that happen for providers, but it really is, it changes your world when your HR system talks to your payroll system, talks to your rostering system, all those kind of things. So please reach out. You've all got my email address. Over the next day or so, I'll download the video from this presentation and send it out to all of you. Have a wonderful day. Talk to you soon. Bye-bye.